Good afternoon. My name is Stefan Kanya. I'm Senior Advisor and Innovation Portfolio Lead at the Office of the National Coordinator for Health IT, which has just recently changed to now being known as ASTP, which stands for the Assistant Secretary for Technology Policy. My role with an organization known as CancerX is I get to serve as a federal co-lead on behalf of the government, engaging through this public-private partnership that we launched just over a year and a half ago. We're excited to host all of you here in DC, for those that are in person, specifically here in the Great Hall at the HHS headquarters. And for those of you tuning in through HHS Live, we're glad you're able to join from afar for the opening plenary and look forward to working with you in the future. This afternoon, we've gathered here in our nation's capital to host an amazing community of collaborative innovators for our second annual CancerX DC Member Summit. Over the course of these next 2 days, representatives from across the U.S. and the world will be engaging in dialogue with each other and across federal agencies about where we can advance the development and commercialization of digital tools to solve some of the biggest problems we face in the field of cancer. More specifically, how can we get more of these tools into the hands of patients and their families, clinicians, researchers, administrators, and anyone else who's fed up with the status quo and is desperate to leverage that technology and data in more meaningful ways to achieve the goals of the Cancer Moonshot, which hopefully all of you are familiar with by now, but just in case you're not. First, to reduce the death rate of cancer by 50% over the next 25 years. And second, to improve the experiences of patients and their families who are faced with immense challenges as they go through a cancer diagnosis, treatment, and the aftermath that often follows. Today, during this opening plenary, you'll hear from several federal leaders from the White House and across numerous agencies under the umbrella of HHS. You're going to hear about their recent effort and future aspirations for continuing the work of the Cancer Moonshot. But before we get into those remarks, there are a few housekeeping items that I'd like to cover. Number one, for those of you who are here in person, if you need to use the restroom at any point, up and to my left or your right, if you follow the signs by the elevators, you can find the restroom. Please feel free to get up at any time and just discreetly walk out. If you need some water or a light snack, we have a table over on my right side or your left side. Feel free to grab a snack at any point. Just try to do it discreetly and quietly. And then for the second half of this afternoon's event, we're going to be splitting up this room into 4 breakouts. One will stay here in this room, and the other 3 will be escorted into different rooms. Hopefully by now, you've selected which one of those breakout rooms that you would like to participate in. If you're not familiar with that, don't worry, we can self-select at the end, and as we transition, I'll be able to explain all of it. But you should have a color-coded sticker, and we'll be holding up signs like this so you know which ones to transition to. And then also, we have a MacBook that somebody, I think, left at the security desk. So if somebody's missing their MacBook, by all means, please step to the security desk. We won't call anybody out. But we want to make sure that you get that back, of course, as well. And then for all of you that are joining us from afar, we're glad that you're able to join us remotely and listen in for this opening plenary portion. Unfortunately, you will not be able to participate in the breakouts. We're not streaming that portion, but we look forward to working with you in the future. And finally, before we get started, I want to thank a few people. We want to thank all those HHS staff who helped make the summit a reality and will be supporting everything throughout the next 2 days. And then finally, of course, I'd be remiss if I did not recognize our co-hosts. The government is just one leg in this 3-legged stool, but our co-hosts, the Digital Medicine Society, or DIME Society, and Moffitt Cancer Center, for raising your hands to help kick off this public-private partnership and get it launched. It started with just those 3 organizations. And then, of course, the entire steering committee for CancerX for raising your hand to be part of the leadership team of guiding the work. And then to all the members who signed up to join it, now 180-plus organizations. So with that, I hope all of you are excited as I am to hear from our federal leaders and CancerX co-hosts, and look forward to an afternoon full of insights and dialogue as we chart our collective future towards ending cancer as we know it. And now, I'd like to kick off our welcoming remarks portion of the agenda by introducing my colleagues from the White House. First up, we have Maureen Clark-Zamborski with the Office of the First Lady. Maureen?
Good afternoon. My name is Maureen Zamborski, and I serve as the Senior Advisor on Cancer in the Office of the First Lady. On behalf of Dr. Jill Biden, I'd like to thank you all for being here today. We know that we cannot meet the ambitious goals of the Biden Cancer Moonshot, reducing the cancer mortality rate by 50% by 2047 and improving the experience of cancer for patients and families without leveraging the vast amounts of data at our disposal. New innovations may be right around the corner, and by combining your expertise and insights in digital medicine, we can unlock progress for patients even faster. As you all know, this work is personal to the President and First Lady. Since day 2 of the Biden administration, Dr. Biden has been meeting with cancer care providers, patient navigators, researchers, patients, and families. Her efforts have led to the historic expansion of access to patient navigation services, which are helping to ensure that no patient has to face cancer alone. Dr. Biden has also served as a tireless advocate for American Indian and Alaskan Native patients, calling for significant investments in the Indian Health Service and tribal health care, including through new Medicare add-on payments for high-cost therapies like cancer drugs. And building upon her decades-long support for breast cancer prevention and screening education, Dr. Biden helped to encourage the nation to return to pre-pandemic cancer screening levels for all cancer types. Thank you again for being here today, for your work as part of CancerX, and for your commitment to cancer patients. Now, I'd like to introduce Dr. Kamal Meghrajani, Assistant Director for Cancer Innovation and Public Health in the White House Office of Science and Technology Policy, who's going to share more updates on the Biden Cancer Moonshot. Thank you.
Great. Welcome, everybody. I'm so excited to see everyone here, and it's such an honor to be here alongside the Office of the First Lady to talk a little bit about the work of the Biden Cancer Moonshot. So as Maureen mentioned, I'm Kamal Meghrajani. I'm an Assistant Director at the Office of Science and Technology Policy at the White House, where I work for the Biden Cancer Moonshot, but I'm also a medical oncologist and a hematologist. So I want to start with a story from the cancer wards. And this is a bit of an amalgamation of different experiences that I had throughout my clinical career, but which hopefully will illustrate the power of digital tools to improve the lives of people with cancer. So I was on call on a Friday evening, because that's always when these things happen, and the emergency department called and said, "Hey, we have a patient down here who we think could benefit from your expertise." So it was around 5 p.m. when I went and met the patient, whom I'll call Mr. C. He was a 42-year-old man, fit, an avid runner, and no other medical problems. And he told me that he'd noticed some bruising on his legs, but he didn't remember bumping into anything. He told me that he would get winded after running just a mile, whereas before he could do 5. And over the past couple of days, every time he brushed his teeth, he noticed a little blood in the sink. And he said, "Is that normal, doc?" And we both knew the answer. So I ran some tests, and I looked at his blood count, and I was concerned that there were some suspicious cells there. There's a type of leukemia, which, if caught early, can be universally cured. But if the diagnosis is delayed, can be fatal. So that Friday night, I went down to the lab, I put a little bit of his blood on a glass slide and looked at it under the microscope. And there those cells were. I was concerned enough that I wanted to start treatment right away, but hospital protocol dictates that we have a pathologist confirm the diagnosis. So now, late on a Friday night, I used our pager system to reach out to the pathologist on call and said, "Hey, I need you to come into the hospital. I need you to confirm the diagnosis." And she said, "Oh, actually, there's no need for me to come in because we have a digital microscope." So I placed the slide onto the microscope stage that had a camera above it, and I was able to capture and transmit the images to the pathologist in real time. With that, she saw what I saw. She confirmed the diagnosis, and I was able to start Mr. C on treatment that very same night. He did well, and eventually was cured of his leukemia because we were able to catch it early. So this is a relatively straightforward digital tool, but even in that simplicity, it made all the difference in getting this patient started on treatment faster so that we could cure him of his cancer. And this is the promise of CancerX, finding new and innovative ways to apply cutting-edge technology to achieve the goals of the President's Cancer Moonshot. So as many of you know, the Cancer Moonshot actually started back in 2016. Then President Obama turned to Vice President Biden and said, "We're putting Joe in charge of mission control." And Joe took the mantle and ran with it, really did shoot for the moon. Cancer Moonshot in its first few years was able to contribute to over 2,000 publications, 49 clinical trials, and greater than 30 patent filings. But when President Biden took office as president, he said that this was one of the reasons that he'd run for the office in the first place. And he reignited the Cancer Moonshot on February 2nd of 2022. He established 2 new goals, which you've heard a couple of times, but I think which bear repeating, that present a clear vision for how we can improve outcomes for those facing these diseases. The first goal is to decrease the age-adjusted cancer death rate by 50% by 2047. And the second goal, to improve the experience of people living with cancer. Now, since the reignition, the Biden Cancer Moonshot has made significant progress through collaborations with the public and private sector, advocacy groups, and federal agencies. Moonshot has accelerated the pace towards achieving these goals. So far, 170 private companies, nonprofits, academic institutions, and patient groups have stepped up with new actions and collaborations. And the Cancer Moonshot has announced more than 95 new programs, policies, and resources to address our priority actions. We've been working hard to prevent cancer before it starts. For example, through enhanced smoking cessation efforts. This work is vital, as smoking is still the #1 preventable cause of cancer, causing about 30% of all cancer deaths and 80% of all lung cancer cases. One of the initiatives to address this under the Cancer Moonshot is a collaboration between NCI's smokefree.gov and the Indian Health Service to provide smoking cessation support through text messaging. Another simple digital tool that could be tremendously powerful in preventing cancer before it even starts. We've been working hard to expand cancer screenings and advance the study of new technologies to catch cancer early, when it could be easier to cure. This includes the NCI Vanguard study, planned as an initial pilot to be followed by a randomized control trial of 225,000 people to evaluate if multi-cancer detection tests can actually save people's lives and prevent cancer deaths. We have been working hard to support and center patients, families, and caregivers, all the way from cancer diagnosis through treatment and into survivorship with navigation services. Cancer navigators guide families through every step of their cancer journey. Navigation services have been shown to reduce the time from getting a diagnosis to starting treatment. They've also been shown to help patients actually complete their entire course of therapy. Navigators can support patients so they don't need to go to the ER as often, and they can help address social determinants of health, such as food and housing insecurity or transportation needs. Through the Biden Cancer Moonshot, the Centers for Medicare and Medicaid Services, CMS, established Medicare coverage for navigation services. And through the leadership of First Lady Dr. Jill Biden, private insurance companies have also stepped up and extended navigation coverage to over 150 million Americans. Cancer centers and oncology practices have joined this effort and have committed to bringing effective navigation support to more communities across the country. And finally, the Biden Cancer Moonshot has been working hard to drive innovation and deliver the latest progress to patients and communities. There are many examples of this, and I'll just give you a couple. The President's announcement in New Orleans last month of $150 million in funding through the Advanced Research Projects Agency for Health, or ARPA-H. And that funding will go towards improving outcomes for those undergoing cancer surgeries. Another is the National Institute of Standards and Technologies, or NIST, updating its research data framework. This work will improve data integrity and increase scientific discovery and innovation with the FAIR principles: findable, accessible, interoperable, and reusable, for better utilization of cancer research data. But a prime example of how we are driving innovation to deliver progress is the very thing that brings us together today in this room. In February of 2023, CancerX was established by the President's Cancer Cabinet as a national accelerator to boost innovation and drive progress against cancer. Just as Moonshot has grown and evolved over time, so has CancerX in its short tenure. From our first meeting together as a smaller group last year at the White House to today's much larger forum, CancerX has made huge strides through efforts like the Health System Core Competencies Guide to support equity and access to cancer treatment and reduce financial toxicity to patients through digital strategies, a solutions catalog to improve diagnostics, aid in treatment planning, and better support patients, and the CancerX Data Sprint to support ASTP's work on USCDI plus cancer and CMMI's work on the Enhancing Oncology model to advance equity in treatment, improve care, and make it easier for patients, clinicians, and researchers to access and use clinical data. Navigation has been a big push of the Biden Cancer Moonshot, and CancerX has contributed the Digital Navigation ROI Calculator and the digitally enabled Patient Navigation Blueprint, which can be used to evaluate which patients may benefit the most and streamline the referral process. And this goes a long way towards directly supporting the Biden Cancer Moonshot's navigation work. CancerX also recently announced the graduates of their inaugural accelerator cohort, and these 16 startups are working to diagnose cancer earlier, match patients to clinical trials, and improve clinical decision support, and more. And this is just the beginning. The transformative power of digital medicine is why you're all here. The President is looking to you to carry this mantle forward, to use your expertise to advance the myriad ways in which digital medicine can improve the future of cancer care. When something as simple as remote review of pathology slides can help a patient get to a cure faster, it's clear that there is so much promise and potential in the work that you all are doing. So thank you for your efforts. Thank you for being here today. Cancer is personal to the President and the First Lady, just as cancer is personal to so many of us, and there's not a moment to waste. Let the conversations you have here today and the work that you will continue when you return home be your contributions to heed the President's call for all of us to work together to end cancer as we know it. Thank you.
Thank you, Maureen and Kamal, for your remarks on behalf of the White House and the Office of the First Lady. It's really amazing having you here today with us, and thank you for obviously your leadership and inspiring all of us to take on this work. This work is a public-private partnership, as you heard stated a few times already. In that public-private partnership, the most important piece, obviously, is the partnership piece of it. And so this next group of speakers that we have are going to be those who represent the three legs of that co-hosted stool that I mentioned before. First up is from our agency, the Assistant Secretary for Technology Policy on the government side, is the Principal Deputy Assistant Secretary for Policy, rolls off the tongue, Steve Posnang. Steve?
All right, thanks. One of our interoperability jokes is whether I can read my own handwriting. So I'd like to go low-tech with the remarks. Thank you very much to our White House colleagues as well, inspiring remarks already today. We are in the Great Hall, where great things happen. And so live up to that today. Very much encourage you to have the conversations that you spent the time traveling and committing on your schedules to be here. And we really appreciate that on behalf of all of our co-hosts, but our office in particular. I am personally excited to have you here. It's amazing to see how large the group has grown since last year. I worked up the courage last year to share a personal story about my experience with cancer. in my family. We have made a lot of progress in the past year, and you all will celebrate some milestones that CancerX has already accomplished. But cancer is omnipresent along our lives. It catches up to us, be it a family member, a parent, a child, a friend, a coworker. We experience this in many different ways, and at times as well, like the story that was shared, it catches us by surprise. And so there are a lot of grand challenges here that we still have to accomplish when it comes to this area of healthcare. And CancerX is a really great example of public-private collaboration where you're here building a community that can help accelerate all of the great things that we're trying to accomplish. So again, I wanted to thank you for your participation, because this is really going to help make an impact in the lives of every American. I often look for analogies when trying to explain the complexity of our work, and this morning I thought of the slide puzzle that I think many of you are familiar with. It's a children's toy, but it's pretty mystifying sometimes when you've got that one empty slot in the corner and you've got to move a piece all the way on the opposite corner, and you have to shuffle 5, 6, 7, 8 pieces all the way around, which is the entire healthcare system, to accomplish the one goal that you set out to achieve. And so, we've talked about burden reduction techniques for our clinical colleagues and data and interoperability, and all of those are different tiles in healthcare that have a relationship to cancer, and in some cases are on the peripheral or an affinity or other types of connection. But we have to move all of those in some type of sequence in order to make progress. And so I just wanted to leave you with that, in that sometimes it doesn't feel like you're making progress, but the incremental steps of action that you're taking, showing up today, is moving one of those pieces around, and you're helping to get it in the right place eventually. So thank you so much for, again, spending your time with us today. Have a great breakout session. On behalf of all of us here, welcome you to headquarters, and I will turn it over to Admiral Levine. Thanks.
Well, good afternoon. Thank you very much for joining us today. I'm Admiral Rachel Levine, and I'm proud to serve as the Assistant Secretary for Health at HHS. So as has been mentioned, at HHS, we are very excited to share the progress of the CancerX public-private partnership for the reignited Cancer Moonshot. As has been noted, cancer is the second leading cause of death in the United States. And death rates are certainly higher in specific minority groups, and these are often linked to the social determinants of health. So as we think of the environment, of nutrition, of access to health care, but also economic opportunity, education, transportation, and more, we have to consider that in terms of different cancer rates. Dr. Marjani was talking about a patient, so it made me think of a patient. So I did my training at Mount Sinai Hospital starting in 1983 and through 1988. And I remember a patient I saw in the emergency room, also Friday night. That has to be when it happens, when I was the senior resident in the pediatric emergency department. And it was a young teenager, probably about 15, who I saw, who was sick, had fever and fatigue. And I examined her, and she had enlarged lymph nodes, she had an enlarged spleen, looked kind of pale, and so the most likely diagnosis would be a virus, maybe it was mononucleosis, but that's not what the blood test showed. The blood test showed that it was very likely that she had leukemia. It wasn't clear, just from the results of the blood test. Again, someone would have to come in and look at the smear. I'm not a hematologist, so I couldn't do that. So we did call pediatric hematology oncology, and there was no technology in 1986 about that. So they did come in, and they did look at the smear, and she indeed did have leukemia. And she was successfully treated, but the family was obviously devastated, and she was devastated. They thought they were bringing in for fever and a virus, and she had leukemia. So that's the type of patients that we're talking about, and they occur for all ages, from my perspective, in pediatrics and in teenagers. The CancerX program, as you mentioned, began in 2023. We are very pleased at my office of the Assistant Secretary for Health to collaborate with the Office of the First Lady, with the White House, and with our colleagues at ASTP at HHS, and have learned lessons from other innovation programs such as KidneyX and LymeX and other innovative programs. And CancerX truly embodies the principle of government innovation, where the government acts as a catalyst. It's not that we know all. We act as a catalyst for collaboration and to infuse fresh energy into innovation into the markets. The CancerX partnership brings together experts and resources from government, private sector, academia, and nonprofit organizations to advance cancer treatment through digital innovation. And it now boasts over 150 member organizations, which is a testament to the dedication and hard work conducted by Moffitt Cancer Center, the Digital Medicine Society, and all of our federal teams together. And we have been making significant strides, as has been mentioned, including the first pre-competitive evidence-based generation project, advancing cancer treatment through digital innovation, the Startup Accelerator, and the CancerX Data Sprint. And so all these fantastic programs which have been going on. And as was mentioned, this is just the beginning. Through the collaborative efforts of our member organizations, we are gaining momentum to move at the speed of industry innovation. And it has matured so much over the last 2 years. You know, there needs to be this multi-pronged approach to fight cancer. Smoking cessation was mentioned. We have cancer prevention efforts through Healthy People 2030, which is through my office, in terms of evidence-based cancer screening and prevention strategies, including increasing HPV vaccine rates. We have a cancer prevention vaccine. We have a safe and effective vaccine that prevents cancer. But because of misinformation and disinformation, we cannot get the rates of immunizations up among our young people. Also, of course, preventing tobacco use, promoting quitting, promoting healthy eating and physical activity, and much more. Another office that we have is our Office of Climate Change and Health Equity, with its sister Office of Environmental Justice, because environmental issues, including those of climate change, can be issues that are triggering cancer. We're also working to address those social determinants of health that I mentioned, and we have a new program called People and Places Thriving. People and Places Thriving. It used to be called ELTRR, with an acronym in the federal government, Equitable Long-Term Recovery and Resilience, but it didn't flow off the tongue so well. So now it's People and Places Thriving, and that's an operational roadmap to build connections and support people to address the vital conditions of health, well-being, and justice. To me, actually, the next evolution of the social determinants of health. And this is just a few of the examples of the work that we're doing at OASH, and they're being done really across HHS. So at HHS, we believe that innovation is a team sport. It has to be done through collaboration. And we want to thank everyone that has dedicated their time to advancing the goals of CancerX. Thank you for your time, your continued support, and together we can truly make a difference. Thank you.
Thank you very much, Admiral Levine. You know, I love that, the speed of industry innovation. I like that. That really resonated with me because it's true, government is not known for moving fast. We try at times, and it's actually Admiral Levine's office that has pioneered a way of doing public-private partnerships. CancerX is just, one in a long line of those partnerships. They've done KidneyX, they've done LymeX, PandemicX, and then, of course, most recently, CancerX. So thank you for your leadership and your support and your partnership on this. But of course, the faster side, the speed of industry innovation, is outside of government. And so really excited to bring up now our co-host on the non-government side, first with Jennifer Goldsack from the Digital Medicine Society. Jen?
Thank you so much, Stefan and Steve and Admiral Levine. So my name's Jennifer Goldsack. I'm the CEO of the Digital Medicine Society, or DIME. And for folks who don't know us, we are a global nonprofit dedicated to advancing the safe, effective, and equitable use of digital technologies to redefine healthcare and improve lives. And just riffing quickly on Admiral Levine's comments there, our unofficial tagline, at least in-house, is clinical quality work on a tech timeline. And certainly every day we show up with all of you, our colleagues at CancerX. You bring that fire, you bring that determination, and this is why this work is such a joy. It's really interesting reflecting on 1 year of CancerX. I remember being here last year with many of you in the room and saying to you that I felt a real sense of responsibility to all of you for dedicating your time and your trust to us. That I felt a real responsibility to the goals of the moonshot, those important life-saving goals, and a real responsibility to being successful in harnessing the power of digital innovation to fundamentally change the way we care for people with cancer, because I deeply believe that there is enormous possibility for change. And I think as we reflect over the last year, we have an awful lot to be proud of. We know that we can be successful in this community. Let's think about a few data points that we have really started to put resources and activities behind, and I am confident that we will be able to move the needle in terms of outcomes and impact. There is a 9% higher likelihood of survival if you are treated at an NCI Center of Excellence compared to any other center in the country. Your likelihood of getting cancer changes based on how much money you earn and where you live. These are the sorts of disparities that we absolutely cannot tolerate. And this is the work that we've addressed, or these are the challenges that we've sought to address through our work over the last year on financial toxicity, when 78% of people who survive a cancer diagnosis suffer from some kind of financial event. The kind of inequity is absolutely unacceptable. We cannot allow the burden of cancer to be distributed in this way, and we have actively worked as a community through applied resources, including an ROI calculator, such that we are giving people the incentive to do it. And this characterizes everything we do at CancerX. We are not just tackling, with your encouragement, the toughest problems to solve for. We are not just coming forward with applied resources to allow every single person who is working in lockstep with us, whether within the community or not, to affect change. We are giving quantifiable business reasons to do it, and then we are celebrating every one of you in this community who is willing to share a case example with us and say, yes, when we do this, it works, and we are proud to share that because that is how we are going to drive change. We show, we don't tell. It has been a really extraordinary year. Add to that the work that we've done in lockstep with our government colleagues, trying to sort of really make sure that we are patient first, science first as we build out US CDI Plus module in oncology. How are we thinking about building the best data sets that we possibly can going forward? The best being the most relevant, the highest quality, the least burdensome to our clinical colleagues, because boy, they do enough already. This is the work that we have been doing, and we have been incredibly impactful. On top of all of this, I can also sort of regale, but I won't because it's being publicly streamed, over a dozen partnerships that have cascaded from all of you in this community. I can talk about the investments that have been made. I can talk about the synergies that we've identified. I can talk about the way that all of you come to the table ready to share your best practices, your experiences, so that other people can take your successes and bring them immediately back to their practices, to their innovations, and they can improve the way we care for people. And then we've already executed our first successful accelerator. We have proven that the market is ready for high-quality, trustworthy digital solutions that solve problems for the people that our industry exists to care for, every person suffering with cancer, and for the systems and the clinical care providers who work hard every day to move the needle. This is an extraordinary amount of progress in just 1 year. And as we think about the breakout sessions coming up, as we think about the celebrations of our success tomorrow, I ask you, keep pushing us. What are the hardest problems that we're going to tackle next? As we move from a year of successful proof of concept, what are the strategies that you want us to pursue? How do we think not just on a year-to-year basis, because boy, we've proven this is real. What's the longer-term approach that you want us to take? We are better, we are more successful, and we are more impactful because of each of you. So I really look forward to a wonderful couple of days. Thank you all for your support, your leadership, your investment, and your passion over the last year. And as we think about planning for the year ahead, let's be as ambitious as we possibly can be, because every single person with cancer, every single person who loves them needs us to be. And with that, I'm going to hand it over to my colleague Xavier from Moffitt.
Thank you, Jen. Thank you, Stefan and Stephen and Admiral Levin for hosting this event and for the opportunity. I'm Xavier Avat from Moffitt Cancer Center, based out of Tampa. And at Moffitt, we have a very simple mission. It's to prevent and cure cancer. So all we do on a daily basis is to figure out how we can prevent and cure cancer. And when the administration and the Moonshot team asked for partners to shepherd this CancerX initiative, Moffitt raised its hand along with other partners like DIME and many others here in this room. I joined the CancerX initiative a few months ago. It was started before I was involved at Moffitt. And from day one, I was really impressed by how structured, deliberate, motivated, driven, passionate the team was in this initiative. Jen shared a little bit of the progress that have been accomplished over a year. I mean, just about a year. So imagine how much work has been going on. In addition to the long list of deliverables, I would add also the accelerator. Many of you here in this room have contributed to this accelerator. We've offered the opportunity to startup companies in the space of digital and AI in particular to bring their solutions to a committee that reviewed them, selected them, and then tagged them with champions, mentors, investors, health systems like Moffitt. And then over the period of 6 months, we tested these solutions. We helped them advance their solutions and their business. And today, several of them have been able to raise money, to be embedded in the workflow, daily workflow of institutions, including Moffitt. So this is how, step by step, we're going to help solve the puzzle of cancer, which is, as we know, a complex disease, but also a complex disease in a complex system. So complex systems is what is puzzling and what is creating a lot of barriers, whether it's access barriers, whether it's financial barriers. And this is where, at least we see at Moffitt and with the CancerX community, the opportunity to harness the power of data and the power of AI in particular to help improve access, to reduce costs, to help improve clinical outcome. Because the trajectory we're on is not sustainable. We're at 20% of GDP. We have outcomes that are, great if we live in cities or close to NCI centers, but as we heard many times over today, if you live outside of these big metropolitan areas, your odds are not as good. And this is where data and AI really can help level the playing field and bring standardization, scalability across the country, maybe even across the world. So this is very exciting to see all these startup companies bringing their respective solutions to help fix our system and improve the odds for patients. I will say, and that's part of where maybe CancerX has an opportunity going forward to continue lead and influence and maybe even shepherd. There is a risk of fragmentation. I see a lot of great solutions that are coming to institutions like Moffitt. And it's sometimes a little overwhelming, honestly, to pick the winners or to select which one is going to really be the one that will make a difference, because we have a big machinery to run on a day-to-day basis. And so all these solutions come one at a time, knock at our door, and we're trying to figure out how to test them, how to compare them, how to select them, and eventually how we can best embed them. So I want to believe that, with CancerX, we're going to have also a role in somewhat harmonizing and bringing scalability to the system so that every patient can really benefit wherever they live, whether it's in Tampa Bay area where we are located, in the middle of Kansas, or anywhere in the world. Thank you again for the opportunity, and looking forward to shepherding and supporting CancerX in the years to come.
Thank you, Xavier and Jen, both for your partnership in CancerX and for all the work you do to help advance innovation in healthcare in general. So now we realize that you've heard from the co-hosts, and we really do appreciate and recognize their willingness to step up and answer that call and provide the platform for all of us to collaborate. But next, we want to be able to show you that it's not just OASH and it's not just ASTP/ONC who are leading this public-private partnership from the federal government side. In fact, a lot of the work is being done by our sister agencies across HHS and even outside of HHS with the VA and other agencies. So at this point in the program, you're going to get to hear from some of those boots on the ground and leaders across the other agencies who are certainly answering the call of the Cancer Moonshot and doing what they can to support it. And I'm excited because first up, we have probably the youngest agency of those with ARPA-H, and a good friend, Dr. Susan Monarez, who's been a longtime supporter and partner of data and technology innovation in general in her previous roles in other agencies. And we were very excited when she moved over to ARPA-H. Susan, if you please join me on stage.
I thought you were gonna. I thought I was gonna be labeled as one of those the youngest participants in the audience. So I'm just gonna go with that stuff. And thanks.
Can you hear me? Okay. All right. Yeah. Apologies for that. I probably should have said that.
Yeah, right? You set my expectations.
So it's been about 2 years since ARPA-H has launched. Has everybody here heard of ARPA-H? Raise your hand if you have. I don't even get that response with ASTP or ONC.
Well, it's because you
Not
keep
even when it was ONC.
We've
been around 20 years.
Name.
Yeah, we've been around 20 years, and we don't even get that response even if we say ONC. So this is great that most of you in this room are familiar generally with ARPA-H. And if I were to ask you, probably no one response they would give would be, they've got all kinds of money to spend. But it's much deeper than that, right? So can you explain a little bit about why ARPA-H was needed and kind of how it got formed?
Yeah, I mean, I think, and especially in the light, first, thank you for having us. This is such a great opportunity for us and such an honor to participate in the CancerX dialogue. There's so much great work that's happening under the auspices of this coordination effort. ARPA-H was launched in the context of needing moonshots. So there is so much investment, and there has been historically so much investment into the health ecosystem. I mean, when you think about it, it's about $4.8 trillion that's going into the health ecosystem. And the way that we thought about ARPA-H in its formulation and then ultimate launch was, we need an organization that can catalyze not everything. It's not going to solve every problem, and it's not going to solve every disease, but it will have the opportunity to take a very high-risk approach to areas that have had long-standing challenges to developing solutions. And one of those is certainly cancer. And so what we think about as we consider what problems we tackle and what efforts that we launch is what's happening across our sister agencies. Where are their investments, and how are we ensuring that we are lifting them up, being complementary? But we also think about what's happening in industry. We don't want to duplicate what's happening in industry, but we want to look for spaces that industry won't take on because it doesn't have a clear path to an ROI. because it's taking on a particular portfolio area or a disease area or something that has just been left behind when it comes to having that partnership resources and equity that help take something from concept into the commercial market. And so that's really where we start to formulate our initiatives. And one of the things, and I love this comment before, is I think Admiral Levine was talking about working at the pace of industry. And that is one of the core principles that we have within our organization, is we don't want to be burdened by some of those bureaucratic or administrative impediments that can really slow down this pace of acceleration. We want to make sure that we are a small and agile organization that's really dedicated on focused, problem solving and working not just at the pace of industry, but working in partnership with industry. So as we're building something, if it is relevant and it can be deployed into the health ecosystem, that we have those transition partners built in. So not only just working with our industry partners, but in concert again with our sister agencies in lockstep, so that our products that we're developing for cancer and otherwise have a greater chance of actually getting into the market and getting to those people who would need the most.
Yeah, and really impressive how you guys have set up the patio and the hub and spoke network. It's been truly amazing to see it all come together, also in just the last year or two. So
we've been
I think
very
we've got
busy,
some shared,
Stefan, very busy.
there. So I know you have launched a ton of programs, and you are getting money out the door. So don't worry, money's coming. But as far as the programs that support the Cancer Moonshot, I know some of them are directly obvious because they're focused only on cancer, and some of them you've been kind of sneaky about, where you've buried cancer, not intentionally, but it's it's a broader goal, but you've made a focus on cancer as part of that. So can you talk a little bit about how some of the specific programs are meeting the goals of the Moonshot?
Yeah, no, it is. So we take a disease agnostic general lens towards what we're trying to create in terms of our product portfolio. But cancer, because it is such a critical driver for morbidity and mortality here in the U.S., we have had some very dedicated intentionality towards our program development. And I'll just give you three very prominent examples that we've launched over the past year or so. Most recently, we launched an initiative called Poseidon. Now, I will never know what these acronyms stand for. They are created by our program managers, and they're lovely, but the actual words escape me. But the goals of Poseidon is to allow screening for up to 30 cancers using a very novel biosynthetic technology that can detect those 30 cancers at stage 1. So this is the type of moonshot that we want to create. If you were to ask anybody, could you create this multiplex diagnostic that would detect at stage 1? Oh, and by the way, we want to make it available for patients to use at home, and we want to use urine or breath as the medium for the sample, so that it is non-invasive. This is the type of thing where most folks are like, that's crazy. Like that, you're never going to be able to do that. That's just not going to work. And what we try to do is actually evaluate the embers. If you looked at all of the pieces of the underlying biochemistry or technology, they all exist. They've just never been put together in the way that we're thinking about doing for the program like Poseidon. So we really think that if we're successful, that could be an incredible game changer to allow us to really move up in terms of the continuum of wellness when it comes to early stage cancer diagnostics. Another program that we launched, which was one of our very first programs, was called PSI, and that was looking at, can we ensure that when we're doing tumor extraction surgical procedures, that we reduce the likelihood of leaving any positive cells or positive margins within the patient in the time frame that they're still in the operating table. So we sort of think about this as a one and done type initiative, which is incredibly challenging from that surgical perspective. And this was something that was, we were very grateful to have the support of the White House and the President just very recently, when we were able to announce the performers, the awards that went out along with that side program, where the President announced it himself down in New Orleans just a few weeks ago. Another one of our programs that we are very excited about, and we're closing in on those awards, is ADAPT. We're actually very fortunate that the program manager, Andrea Bild, is here with you today, and I'm sure she will be more than happy to talk more extensively. She is a very prominent scientist in the oncology world, and so has a great depth of knowledge. Her program is really looking at how do you keep pace with a tumor evolution over the course of treatment, which really is such a critical piece of ensuring that the chemotherapy that is being used in the patients is the most appropriate one to address that tumor as it evolves over time. And so she's created this really innovative approach to develop new biomarkers that can be used in almost real time as that tumor evolves to ensure that the chemotherapy is the right one at the right time for that particular patient. She's also coupled that with ensuring that the clinical trial protocols associated with that, with the treatment protocols for that patient can adapt so that the patient doesn't need to change anything associated with who's treating them or where they're getting treatment. And so we're very, very excited about that program. We also think that that's going to be a game changer. So those are the broader ones that we have launched that are associated with cancer. But we do have some of those that are underlying, like one that we're working closely with I was going to say ONC, but you're not ONC anymore, the biomedical data fabric. And that is looking at how do we get the right data that's being generated from the research bench related to oncology, to clinical trials, to other real-world evidence that can be brought together to help accelerate the full R&D ecosystem related to cancer and other diseases as well. But cancer is a true focal point of that initiative, and we're very excited about our partnership with ONC, with NCI, with many parts of NIH as well, to try to make sure that the data that's relevant to those of you who are producing or trying to develop different capabilities across the various aspects of cancer have access to the same data that we do and others to enable you to create the best outcomes through your product development.
Yeah, and it's the last one that you mentioned is one that I'm really excited for, a little selfishly, because we've been so involved in it. But we know that data is the fuel for so much innovation. And that's why we support, US CDI Plus for cancer and are developing that out. And it's great to be able to collaborate with you to make sure those things are all aligned.
Yep.
And then also the ACTR, right, or Advancing Clinical Trials Readiness, has a little bit of flavor, a focus on cancer as well.
Yeah, so we do have another initiative that we're still, we've announced publicly, and we have sought some additional input from the broader community, including the cancer community. Accelerating Clinical Trials is looking at opportunities to create different data tools to share information across clinical trials and the organizations, the CROs and the organizations that are seeking to work through clinical trials, so that we can expand the reach of those clinical trials to meet the needs of all who would benefit in the time that they would benefit. And so we're really trying to think about, interoperability as one of those core elements. We're trying to make sure that we have, that we're creating a network of networks of clinical trial locations, so that if you have a need or an ability to participate in a certain clinical trial related to whether it's cancer or some other disease, but you happen to live in rural Iowa or southeast Missouri or any of those places that may not have currently been integrated into a clinical trial network, that we don't unintentionally promulgate the sort of the divisions that we have in health equity. And so I think ACTR is going to be one of those areas that helps not only cancer but many other diseases as well.
Great. And so as we wrap up here, because we do have other agencies that we are excited to hear from, next 5 to 10 years, anything you could preview for us as far as your priorities, where you guys might be going? I know you can't give it all away. It's not public information, but what can you share with us?
Yeah, I mean, we're very excited about what we've already launched, specifically related to CancerX and the cancer space. But two areas that we're continuing to build out within our own organization that will have cancer-related elements as well as others is prevention. So how do we actually upstream the continuum of wellness? What can we do that is innovative and meaningfully to try to mitigate the risk of whether it's cancer or diabetes or other things. And this is a very, very hard area to explore for an organization like ARPA-H that is really tech forward. So a lot of the work that we do is creating new technology, whether it's med tech or it's actual biomedical innovations. But what can we do on the prevention side to help reduce the chances that someone gets cancer or anything else? So we're really focused on where's the opportunity to innovate in proactive health and in that space. The other area that we're really excited about is in scalable solutions. So probably many of you in this room have had this experience where there appears to be a solution that has been proven out successful in a very limited circumstance. So maybe a small patient population or a very specific, a very narrowly focused clinical indication. And what we want to do in that sort of scalable solutions sector is say, how do we take something that has been proven to work and that could really benefit so many others that are afflicted with the same condition and get it through all of the scaling activities necessary to distribute it to all who would benefit? You know, when we talk about this, it sounds very easy. And people are like, oh, you just make more of it. And those of you who have ever been in an experience where you see that thing over there and you're just like, I can't get to that thing because it's cost prohibitive, or there's just no mechanism to be able to distribute it as broadly as necessary. There are innovation steps that need to take it from 0 to 1 to 1 to many. And so we're looking at how do we make investments to help scale some of these very valuable capabilities that have had that initial proven capability, but has not yet scaled to all who would benefit. So forecasting in those two areas, we're very, very excited. And then we'll continue to try to build out across the health ecosystem to touch everything that would benefit our patients, our providers, try to figure out, opportunities to incentivize and improve on the payment side. And then, of course, infrastructure is always on our mind.
Well, as you said, it's great to know that you are helping people realize that things that may seem easy aren't, and then more importantly, with your programs and staff are helping them try to tackle those things in a meaningful way. And then to your earlier point, also the one that I've always been inspired by is that as you guys are looking at things where people think you're crazy and there's no way you can get that done, you have the passion to go behind it and say, we're going to figure out a way, and let's see what the evidence says, and let's see what we do have available to us to make it happen. So thank you very much, Dr. Monarez, Deputy Director for ARPA-H. We appreciate the work that all of you are doing there. And we'll transition out to our next agency. Thank you.
Thank you, Stefan. Thanks, everyone.
Okay, so now ARPA-H, some of you maybe heard of them and now hopefully have a better sense of the work that they're doing, but also how they're doing it, and more importantly, how they're doing it to support the moonshot. The next agency that we're going to have present is actually, it's going to be a recorded video, unfortunately, because they weren't able to be here in person. But they're a little bit more obvious. Everybody's a little bit more familiar with this agency when it comes to the topic of cancer. So as you can guess, it's the National Cancer Institute at NIH. And we have with us Warren Kibbe.
To achieve President Biden's goal to reduce the cancer mortality rate for all Americans by 50% by 2047 and improve the experience of all people living with cancer, we absolutely need innovation and need good data to answer the many pressing questions we still have to solve in problems in cancer. And we must work toward a future where data, tools like AI, are leveraged to their fullest potential to the benefit of all patients. These advances in technology and data cannot come from any one agency, company, or individual acting alone. But through collaboration, we can solve these challenges together. That's what makes initiatives like CancerX that bring the public and private sector together such a great vehicle for progress. I had the opportunity recently to see CancerX's potential and the power of this public-private partnership initiative and the power that it can bring to our work. I met with one of the NCI-designated cancer centers as part of the CancerX process, and they were so enthusiastic and excited to see the collaborations that are possible through CancerX and the way they can bring startups into the clinic. The ideas they're working on offer real promise to advance different aspects of cancer care through the better use of technology and data, including using data from EHRs to help match patients better to clinical trials, giving patients and clinicians a dashboard to see where the patient is in their care trajectory and know what treatments they've gotten, help patients journey their experiences as they move into survivorship. Ideas like these really zero in on a great place for innovation by focusing on the workflow of cancer investigators as they also serve as caregivers, embedding research into the patient experience and on the patient experience itself. These are such great examples of the types of challenges that CancerX is focused on. I also want to highlight that the NCI SBIR program has 2 companies that are currently participating in CancerX and with a focus on digital health technologies. Each of these companies will be participating in the accelerator and, of course, in the SBIR program itself. Of course, there are many areas across our work that are ripe for new technological approaches. As we look to drive further innovation in cancer science and care, it's absolutely essential that our sights are set on the key areas that will reduce cancer burden for everyone and leave no one behind. This is where the cancer plan, the National Cancer Plan, is especially useful. It provides us with a roadmap to align and focus our efforts across society to achieve the cancer moonshot goals. I'm a data guy, so the plan's goal to maximize data utility naturally speaks to me. And the imperatives I see are really in improving access to data, enabling innovative approaches for generating and utilizing data in cancer research, and using data science to advance our understanding of the basic mechanisms of etiology of cancer. The plan's goal to engage every person is crucial to maximizing data utility. The mark we must reach is to ensure that we have data that adequately represents the incidence, the exposure, the experience, and the outcomes for all populations. We also need both a data science workforce and a cancer research workforce that's equipped with data science skills to take advantage of AI and learn from data and ensure we don't draw the wrong conclusions that could have negative consequences or leave populations behind in their cancer experience and journey. And that workforce needs to be reflective of our country if we want to achieve health equity. In my role here at NCI, each of these areas are ones I'm very focused on. And I strongly encourage everyone here at the summit to keep in mind what role you can play in engaging every person, maximizing the value of cancer data, and ensuring our workforce is equipped to seize all the opportunities for progress. I'm very excited to see what comes out of the summit today and look forward to continuing the conversation as we at NCI seek to understand how we can best support our nation's broader efforts against cancer. Thank you.
Glad we got that working. And thank you to Warren for sending that message. I know he desperately wanted to be here. It just didn't work out this time. There's other work going on. Next, we have our good friends with the FDA, the Food and Drug Administration, and specifically Paul Klutz, the Deputy Director at the Oncology Center for Excellence. Paul?
Well, we're definitely not the youngest agency. I'm definitely not the youngest speaker, but the Oncology Center of Excellence is actually pretty young, as you'll hear about. So good afternoon. My name is Paul Klutz. I'm a medical oncologist. I'm serving as the Deputy Director for the Oncology Center of Excellence within the Food and Drug Administration. Since I began in 2010, the cancer treatment landscape has been absolutely revolutionized. I think everyone would agree with that. And I've been fortunate to sit at the front seat of that, from early drug development to the pivotal trial to the review and approval of a lot of these drugs. And it's been incredible. But while much progress has been made, I think we can all agree that there is a lot of work to be done. Most cancers remain incurable. Existing treatments still come with high side effect burden, and it's difficult for their families and patients to go through it. And unfortunately, as I think you've heard, diagnostic tests and treatments are not equitably distributed throughout the United States. So there's a lot of questions that remain, and it's not just questions about evidence for new drug approval. After approval, the questions remain, what's the best sequence of drugs to use? For two effective therapies, which one is more effective? Which one's more tolerable? Can we de-escalate treatment? Can we have the similar efficacy with less duration of therapy or with a lower dose even? And increasingly, what's the safety and efficacy of our approved drug in populations that weren't well studied in the pivotal trial? This is a big problem. So racial and ethnic subgroups, older adults, etc. So whether we're developing novel treatments or whether we're optimizing how to best use what we have now, what we need is high-quality evidence. And we need a lot of it, and it is not possible to generate this evidence through what has been traditionally large, complex, prospective, randomized trials. We need to modernize how we generate high-quality evidence. So let me take a moment first to give you a little overview of the FDA and the Oncology Center and just a couple of the programs that we have that I think are directly relevant for today. At the FDA, there are 3 product centers that review cancer products. One is CDRH, which is for devices, critically important in vitro diagnostic tests now for precision oncology. We also have the Center for Biologic Evaluation and Research. This is super exciting, immunotherapies, adoptive T-cell therapies, vaccines. And then we have CDER, the Center for Drugs, so chemotherapies, therapeutic antibodies, et cetera. And all these centers are organized around the product type, as I've demonstrated, biologics, drugs, devices. But a relatively new center, the Young Center, the Oncology Center of Excellence, was authorized by the 21st Century Cures Act and established in 2017 as the first inter-center institute that is actually focused on a disease, the disease of cancer. Obviously not one disease, but a relatively homogeneous set of diseases with similar natural histories, similar endpoints. Clinical trial designs are somewhat similar. And so the OCE provides subspecialized clinical oncology expertise across all those product centers that diagnose or treat patients with cancer. So since its inception, and I was one of the first 12 or 13 folks that started this small center up, we have initiated over 40 programs and innovative regulatory review pilots. We've centralized programs to help the review of all these products across the centers, including medical oncologists that are steeped with pediatric and rare cancer expertise, oncology product labeling and safety. We have a project called Project Facilitate, which is a call center for physicians who want to gain access to an investigational drug for a patient who may not be eligible for a clinical trial. And we have a lot of outreach and engagement in scientific efforts. Just a couple, Project Orbis, an international regulatory harmonization project where we do parallel reviews of innovative therapies that's led to earlier availability across the globe of some of the most exciting cancer therapies. Project Community brings together patients, advocates, and families from those living in underserved urban and rural areas. And I think a really interesting program, Project Catalyst, is intended to provide regulatory guidance and outreach to small biotech and academic life science incubators. These are small groups that don't have in-house regulatory expertise and often not the funds to get a consultant. So what about programs that are directly, I think, relevant to digital health technology? These are some of the most exciting programs and fun programs in my mind. Because again, we have to broaden our data sources and modernize how we're running prospective research if we're going to answer all these questions. One of the programs is called the Oncology Center of Excellence Real-World Evidence Program. This is obviously focused on advancing our understanding of how we can use data sourced outside of clinical trials, so electronic health records, registries, et cetera. This program, over only a few years, has led to a couple of, I think, important outcomes. Number one, they are being deployed across the centers to do real-world data submission reviews. We have pharmacoepidemiologists that have looked at over 100 products around per year and meetings providing high-level support. We've been looking at real-world endpoints in the EHR. What can we use as outcomes in the real world? Things like time to treatment discontinuation, time to next treatment. What does a real-world clinical response look like that we might be able to start to look at? We've created a real-world evidence glossary, provided leadership for this cross-agency effort to create sort of a general glossary of terms culminating in the FDA-NIH resource on terminology for clinical trials. And we've created what's called the oncology Q card. We get a lot of real-world data study submissions to the FDA, and they're often pretty heterogeneous in the quality of that submission. So we've created a group of the most important study characteristics that should be submitted for us for rapid review so we can give advice back quickly to those who submit. We're obviously very interested in improving EHR source data quality, and that's a lot of what you've heard with ONC and some of the other projects ongoing, which we're collaborating with, including MCODE and US CDI+. Another area that's of great interest of mine is how do we actually assess, quantify a patient's symptoms and function? And obviously in patients undergoing treatment for cancer, this is critically important. We're talking about very symptomatic diseases, and as anyone who's had a family member go through cancer treatment, often quite a bit of side effects as well. So we are looking for electronic patient-reported outcomes, wearable devices, and other digital health technologies that can help us quantify the patient's experience while undergoing cancer treatment. This group, the Patient-Focused Drug Development Group, has been very successful in leading annual meetings that are internationally attended on advancing electronic patient-reported outcomes. And we're conducting some research that's applied and is going to be directly relevant to our review work. I just want to mention one. It's called the INFORM study. It's a collaboration with Yale and Mayo, where we are prospectively studying over 200 patients undergoing treatment for lymphoma and for breast cancer. And we're looking at assessment of physical function with 4 different kinds of modalities: electronic patient-reported outcomes, clinician-reported ECOG performance status, a 6-minute walk test, and a wearable device, in this case, the Fitbit. Because we want to understand what's the feasibility of deploying these in trials. We want to understand what is the sensitivity to change for each of these modalities. And we want to compare them and understand what is a meaningful change. Is going from 1,000 steps a day to 800 steps a day meaningful to patients? You know, a lot of times when you have that kind of fidelity, it's hard to imagine and understand what's meaningful. We also have one important and interesting activity going on with the National Cancer Institute, where we're looking at facial recognition as a way to understand a cancer-related pain. That's being led by James Gully, my friend and colleague at the NCI. I'll end by saying, you know, prospective research is also a huge opportunity. We all need to understand that the best evidence we're ever going to get is randomized trials. Randomization is an incredible design that allows us to really understand that the effect we're seeing is due to the drug and not to some confounding influence. So what can we do to help prospective randomized clinical trials? We have a great interest in trying to deploy randomized trials into standard routine care, so-called pragmatic trials. We have a project called Project Pragmatica. And then, as I think you heard, you know, we have a lot of patients living hundreds of miles away from National Cancer Institute centers. So can we decentralize some of the trial conduct, labs, imaging, use of telehealth? Those decentralized trial aspects are really important to the FDA. So hopefully that gives you a flavor of a couple of the things that we're doing at FDA, and that's just within the Oncology Center. We have many other activities, obviously with CDRH's Digital Health Center of Excellence as well. So I'll end where I began. I'm very enthusiastic about where we are now compared to where we were in 2010 when I began at the FDA. But we got a lot of work to do. There are many questions, and we need to help identify ways to equitably get the tests and the therapies out to patients who need them. We need to modernize evidence, and we're not going to be able to do it alone. We're going to have to join forces. And today, you know, we have an array of U.S. government industry stakeholders that are all doing their part to find ways to generate high-quality evidence. And I think all of us understand that, you know, digital health technology is going to hold a great promise, and it's going to play a substantive role in solving some of these problems. So thank you so much for your attention.
Thank you, Paul. So now we have our final agency for this portion of the opening plenary. With the Centers for Medicaid and Medicare Services, and specifically at CMMI, we have got Kate Blackwell, which, here she is, okay. I was like, I didn't see her over here. Kate is and her team at the CMMI is doing amazing work as it relates to the EOM program in thinking through how they can incentivize adoption of tools in supporting patients for the moonshot. So with that, Kate, please come to the stage.
Good afternoon, and thank you all so much for the opportunity to be part of this CancerX event today. I'm Kate Blackwell, and I'm a Division Director at the CMS Innovation Center. We at CMS continue to be excited to participate in and support President Biden's Cancer Moonshot, especially given our commitment to improving care and the care journey for cancer patients. By way of background, the Innovation Center was created by the Affordable Care Act, and our mandate is to design and test alternative payment models for Medicare, Medicaid, and CHIP. The goal of these alternative payment models is to improve quality, reduce costs, or ideally both. Focusing in on our models, we run tests where we take a piece of Medicare and Medicaid and run it differently than it normally would operate. So we can change what we pay for or how we pay for things. We can change or waive rules to give clinicians additional flexibility or require them to do additional things above and beyond what they normally do. And we can share information and disseminate best practices. We run these models for a limited period of time, and then we evaluate whether or not they worked. If the model worked, and by worked I mean save money, improve costs, or ideally both, then we can consider expanding the model. Expansion can look like a number of things, with the ultimate endpoint being making the model or parts of the model a permanent part of the Medicare program. Even if a model isn't certified for expansion, we can take lessons learned and carry them forward into the Medicare program. In that way, the Innovation Center really aims to drive system transformation and lead the transformation from fee-for-service healthcare system into a system that focuses on value-based, patient-centered care. To digress briefly here, this point is of particular importance in what brings us all here today, and that is that information plays a key role in our work, both at the Innovation Center and for CMS generally. I'm thinking both about the flow of information between CMS and clinicians and model participants, and I'm also thinking about putting that information to good use. Accurate and comprehensive data supports operations, enables the evaluation of performance, and can be an important resource for participants in our models working to transform care delivery. I think we all know, however, that actually putting these concepts into practice is harder than it might seem on its face. Different healthcare providers have different levels of sophistication when it comes to collecting, transmitting, receiving, and using data. Collecting data can be burdensome, and transforming data into something that is useful and actionable in a clinical care setting isn't always as obvious as it seems. This is a place where the work of CancerX is really exciting for us at CMS as a way to accelerate innovation in this space that is so vital to transforming the healthcare system and improving care for patients with cancer. Turning back to oncology, testing ways to improve oncology care through alternative payment models has been a consistent theme throughout the Innovation Center's brief history. In 2015, we announced the upcoming launch of the oncology care model, our first cancer-focused model, which was a catalyst for many oncology practices to provide high-quality, person-centered care. When OCM ended in 2022, while we didn't expand that model, we did take lessons learned from that model to inform the development of our current model, the Enhancing Oncology Model, or EOM. While EOM was being developed in early 2022, the call to action from the Biden-Harris administration and the reignition of Cancer Moonshot was also announced. Together with the Cancer Cabinet and the rest of CMS, we recognized early on that EOM would be vital in supporting the work of Cancer Moonshot's goals of improving experience for people and their families living with and surviving cancer. EOM began formally in July of 2023 and is now scheduled to end in 2030. We have over 40 oncology practices participating across the country, and we are currently soliciting applications for a second cohort, so if you know any oncology practices who are looking to sign up, now is the time to tell your friends. Like OCM, EOM incentivizes oncology practices to provide value-based, person-centered care to patients with select cancers in Medicare. We have already been able to capitalize on the convergence of EOM, Cancer Moonshot, and CancerX in particular in the design and implementation of EOM. In terms of driving new innovation, the Biden-Harris administration has kickstarted the adoption of USCDI plus cancer, and EOM requires oncology providers to submit clinical data elements to CMS as part of their participation. These data elements cover vital information about a person's treatment history, test results, and disease status, and EOM data elements form the core of USCDI plus cancer. So we can drive widespread adoption and inclusion of USCDI data elements in the electronic health records. Supporting cancer patients and caregivers, EOM builds on lessons learned from OCM that supports participating practices in integrating care coordination and patient navigation services into their models. These models incentivize oncology providers to offer coordinated patient-centered care, which includes navigation and support. Last year, CMS established social determinants of health and patient navigation codes in the 2024 physician fee schedule to provide additional support for these services. In addition, both CancerX and our oncology models have recognized how in the cancer care journey, the costs of treatment and care are a major concern for patients and their caregivers. OCM and EOM have integrated requirements on financial transparency with patients about the costs of their care, including requiring discussions with patients about their out-of-pocket treatment costs. We at CMS are encouraged to see that CancerX has been developing tools and advancing digital innovation to reduce financial toxicity for cancer patients. These are just a couple of examples of places where innovation in digital tools to support oncology care are being integrated into the payment system to drive system transformation and to improve patient care. But it is by no means the full extent of the potential in this space. And with 6 years left in the Enhancing Oncology model, I'm really excited to see where we can go. And as I said earlier, the ultimate goal of EOM and all of our models is to expand or incorporate them into the permanent program. So while I'm talking about priorities for EOM in relation to data sharing and the use of information, what I'm really talking about is what the future of information and data use looks like in Medicare oncology care and in Medicare more generally. Zooming out, we recognize that improving the cancer patient experience and supporting patients and their caregivers is a significant effort that cannot be achieved by a single entity working in isolation. To make meaningful progress towards achieving patient-centered cancer care will take a collective effort across the federal government, like we've been talking about today, in partnership with other payers, providers, patients, and their caregivers. CancerX is an excellent example of a public-private partnership that has been established to act as a national accelerator to boost innovation in the fight against cancer. This partnership is critical, and we're thankful to be part of it. At CMS, we have benefited from the Cancer Moonshot as we seek to improve cancer care for patients in Medicare, Medicaid, and CHIP, and beyond. We look forward to continuing our partnership with CancerX and to continue this much-needed work to improve care for cancer patients. Thank you.
Thank you, Kate, to you and your team for all the work you've been doing to try to provide that payment pathway to support all of this. And of course, for being such a great partner with our agency at ASDP and all of our other federal colleagues. Okay, so at this point, some of you may have been wondering, we were hoping to have some time for Q&A. Unfortunately, we ran a little short on time. There's just too much good news to share with all of you and so many things that the agencies wanted to share. However, for those that are here in the room, at this point, we're going to start to transition into the breakouts. And in addition to the federal leaders that you saw up here presenting, there's a number of other federal staff that are sprinkled throughout the audience and will be joining in each and every one of those breakout rooms. So you'll have a chance to interact with and engage with them when we have these more focus-based discussions. As far as the live streaming goes, we could probably cut the live stream at this point. This concludes the portion of the opening plenary.
Produced by the U.S. Department of Health and Human Services.